Hi, and welcome to the VieSID Press-release. In this video, we report on the dental literature published in April 2022. We have chosen articles from a selected list of journals that we think might be of interest to the VieSID community. So let's begin. In the Acta Odontologica Scandinavica, Sagafi et al. Assessed the prevalence of temporomandibular disorders before and after curative oncological treatment to identify possible risk factors. They considered 217 patients with squamous cell carcinoma in the tonsils or at the base of the tongue, treated with radiotherapy and chemotherapy, but excluded those subjected to surgical intervention. Assessment of TMD symptoms was carried out before treatment and after 6 and 12 months. After 1 year from radiotherapy, significant increased muscle pain was detected through palpation, and pain while chewing was self-reported. Additionally, patients showed a significant reduction in mouth opening. These results are in agreement with previous studies indicating that radiation dose to the masticatory muscles and TMJ can predict the development of restricted mouth opening. This might occur several months after treatment and be associated to muscle stiffness and pain. However, physiotherapy helped reducing muscle and TMJ pain. Furthermore, the authors concluded that the patients with TMD symptoms and restricted mouth opening reported a worsening of their condition, but these outcomes cannot be verified based on the information in the text and tables. Psychosomatic effects might also play a role in the pathophysiology of TMD in cancer patients. In the same journal, Tatoglu and colleagues investigated changes in bite forces in TMD patients treated with anterior repositioning spleen therapy. The bite force was assessed using a flexiforce sensor, which is in the picture, in 22 patients with this derangement and this dislocation with reduction based on the diagnostic criteria of temporomandibular disorders. 22 symptoms-free subjects were also included in the analysis for comparative purposes. At baseline, bite forces were not significantly higher in the controlled subjects than in patients with these displacements, as shown in Table 2. In Table 3, significant force bite increase is shown for the displacement patients after the spleen therapy was worn for 6 weeks. The authors explained these outcomes, arguing that the length of the elevator muscles and the position of the condyles in the articular fossa might be altered by increasing the occlusal vertical dimension, which in turn affects masticatory function and also biting force. The increased muscle forces in these derangement patients after treatment is in agreement with other studies. However, in contrast to previous findings, Tatoglu and colleagues did not find significant different bite forces between TMD and controlled subjects. I wonder whether occlusal vertical height is a factor influencing the outcome of this study. In the American Journal of Orthodontics, Ning et al. Investigated changes in upper airway volume of 57 Chinese adults age 20 to 35 years with hyperdivergent face after orthodontic treatment involving premolar extraction. Patients had fixed orthodontic treatment with extraction of the first premolars of the upper arch and the second premolars of the lower arch, and were given moderate anchorage without screw implantation. The orthodontic treatment resulted in a 3 to 4 millimeter mesial movement of the molars, retraction of the upper arch incisors, and decrease of the mandibular plane inclination. They measured the volume of the upper airway before and after treatment, dividing it into 4 portions: the nasopharynx, the palatopharynx, glossopharynx, and hypopharynx. So afterwards, the authors analyzed the outcomes after dividing the sample into 2 subgroups, Those with elongated mandible, so with a gonian to gnathian length higher than 122 millimeters for males and 115 millimeters for females, and those with shorter mandibles. So Nind and colleagues found differences in the hyoid position and an increased glossopharynx and hypopharynx volumes, as well as minimum cross-sectional area and anteroposterior linear distance in the patients with elongated mandible, while no differences were found for the patients with shorter mandibles. They therefore concluded that the premolar extraction in hyperdivergent adults with favorable mandible length can facilitate improvement of aesthetics, hyoid bone position, and might increase glossopharyngeal and hypopharyngeal volumes. The results of this research should be interpreted in the light of the study design and some of its limitations. The subdivision of the sample into two groups based on the mandibular length was carried out using an arbitrary cutoff value, while this cutoff value, if present, should be determined based on the scrutiny of the outcomes. An assessment of the intra and inter-observer errors were not performed. Thus, errors in data collection might account for part of the differences observed. Moreover, it should be stressed out that the authors focus on the volume of the upper airway and did not evaluate any other clinical and functional aspects of the orthodontic treatment, nor an assessment of the clinical significance of the increased volume was performed. In communications biology, we found an account of the trigeminal ganglion vasculature by Gozigo and colleagues. The trigeminal ganglion is small and deeply located, therefore difficult to image. It contains the cell body of the primary sensory neurons for the ophthalmic, the maxillary, and the mandibular nerves, reacting to chemical, mechanical, and thermal stimuli. Therefore, its anatomy is relevant for the understanding of orofacial pain conditions. The authors imaged the trigeminal ganglion blood vasculature at microscopic resolution and measured the hemodynamic responses evoked by orofacial stimulations in anesthetized rats. They demonstrated that the activated trigeminal ganglion area was different for ophthalmic and maxillary territories, a small but deeply localized area for the ophthalmic branch, while the area responsive to the maxillary branch was localized more superficially. The authors used an innovative approach for the imaging of the trigeminal ganglion vasculature, namely the ultrasound localization microscopy combined with in-total labeling that permitted detection of particular feature of the vascularization. With this approach, they were able to image and quantify a strong and highly localized hemodynamic response in the ipsilateral trigeminal ganglion, evoked by mechanical or chemical stimulations of the corneal nociceptive fibers, but also by cutaneous mechanical stimulations of the ophthalmic and maxillary orofacial regions using a von Frey hair. Thus, they confirm that the trigeminal ganglion is highly vascularized with a dense network of tortuous blood vessels. The organization of the vessels differs from that of any other vascularized cerebral structures in the sagittal plane imaged. The direction of the blood flow within the trigeminal ganglion was irregular, with two large tendencies, a ventral posterior flux from the caudal part of the opposite on the rostral part, and the blood flow differed also for its variable speed. So this response was surprising given the small number of sensory neurons within the trigeminal ganglion. And this approach, the authors concluded, might also have further application in the study of trigeminal pain conditions. In the Journal of Oral Rehabilitation, Asquini et al. Reviewed the literature assessing effectiveness of craniomandibular manual therapy on pain and maximum mouth opening in TMD patients. For craniomandibular manual therapy, they meant any hands-on treatment provided by the physical therapist. The authors considered initially a total of 2,720 articles, of which finally only 6, accounting for a total of 293 participants, satisfied the inclusion criteria. The selection criteria were as follows: adult participants, so age 18 years or older, with a diagnosis of TMD according to either the research diagnostic criteria for temporomandibular disorder or diagnostic criteria for TMD, or any other study with a population reporting signs and symptoms of TMD. Asquini and colleagues found that the small number of included papers showed heterogeneity of TMD type, like chronic, acute, myogenic, arthrogenic, or mixed, so that the studies were grouped for outcome measures instead of TMD type, as stated in the initial protocol. The kind of treatments were also varied and included intraoral myofascial therapy, oscillatory grade for TMJ mobilization, facial massage, and manual therapy applied to TMJ and masticatory muscles and masticatory muscle trigger point release. There were also heterogeneity in the comparative type of sample. Some of them used the sham treatment or control group or self-care and exercise, splint or kinesiotape, and photobiomodulation therapy. And assessment point, so immediate post-treatment, 5 days, or from 4 weeks to 1 year. So overall, the quality of the evidence was very low for all the outcomes because of high heterogeneity and small sample size. The studies showed a significant reduction of pain and increased maximum mouth opening from baseline in the midterm, but only 2 showed superiority of the manual therapy compared to other interventions. The neurophysiological response following manual therapy also was found to decrease tissue spasm and increase range of motion. In the Journal of Oral Rehabilitation, Juan et al. Compared 3 different murine models to investigate the mechanism, prevention, and treatment of temporomandibular joint osteoarthritis. In particular, the mechanism they assessed the applicability of surgery, injection, and crossbite approaches to induce osteoarthritis by considering pathological changes in the cartilage, subchondral bone, osteoclast, and synovium after 3 and 6 weeks from exposure. In this image, you can see the macroscopic alterations of the disc after procedures which can be compared with the disc in the sham group on the left side. In the sham group, minimal surgical procedure was conducted to mimic incidental effects, but without induction of TMJ osteoarthrosis. In the surgery group, the lateral disc of TMJ was resected. In the injection group, type 2 collagenase was injected into the articular cavity of the TMJ. And in the crossbite group, 2 metal tubes were bonded to the left maxillary and mandibular incisors to induce unilateral anterior crossbite. The authors observed osteoarthritis-like changes in all of the models that induced damage of disc, degradation and destruction of condylar cartilage, subchondral bone loss, and different degrees of synovial inflammation. In the injection group, the articular disc was the most damaged since it became very rough and had uneven thickness. In the surgery group, the fibrous layer of condylar cartilage narrowed down, and the cells in the increment layer were disordered after 3 weeks. At week 6, local cartilage damage extended to the subcondylar bone. In the crossbite model, the thickness of the condylar cartilage decreased significantly, and there was also a peeling of partial cartilage from the condyle in 6 weeks. So, in this image, you can see the outcome of the study on the articular disc using the safrarin or fast green staining technique and using the immunofluorescence techniques. In conclusion, the authors suggested that surgery could be an important resource for the assessment of post-traumatic TMJ osteoarthritis and subcondylar bone changes in early stages. Injection instead induced a severe end-stage osteoarthritis in short time and provided model basis for advanced TMJ osteoarthritis. Crossbite was found to be a more suitable model to explore the pathogenesis of temporomandibular osteoarthritis due to occlusal disorders. So we come to the end of this presentation. I invite you here to contact us in case you want to know more about our activities. Otherwise, be ready for next press release. Best wishes to all.